item on the agenda is approval of the minutes. Can I get a motion? Second.
Second.
Any edits?
I looked very hard, but I could only find one that I think is an actual error, and it's right in the beginning on page 5, line 24. The word revision, I think, should be provision.
All right,
We love it.
so we'll make that change. All in favor?
Aye.
Any opposed? Abstentions? Terrific. We will now move on to notice of adoption to amend Article 11 and, Article 11. And we're going to have a presentation. Dr. Daskalakis, please.
Good morning, everybody. Thank you again. So today we're going to talk about it. Oh, I need to speak into the microphone. Is that better?
Yes.
Yes, sorry about that. So today I'm presenting proposals to amend Health Code Articles 11 and 13. Briefly, a summary of the proposal. We want to amend Articles 11 and 13 to require laboratories to report all test results for tuberculosis infection. Amend Article 11 to require healthcare providers to test pregnant persons for syphilis at 28 and no later than 32 weeks of pregnancy and document said test results and a treatment plan in the medical record. Amend Article 11 to provide the health department with greater discretion to end exclusions of persons infected with enteric pathogens. And to amend Article 13 to no longer require laboratories to perform culture testing on all specimens found to be positive for Campylobacter by Culture Independent Diagnostic Test, or CIDT. In terms of the rulemaking process, the Board of Health approved publication of proposed rule on June 11th, 2019. There was a public hearing held on July 22nd, 2019, with no comments offered. We did receive 3 written comments. 1 comment in support of syphilis screening proposal, which I'll review briefly in the presentation, and 2 comments requesting clarity regarding the TB infection reporting proposal, which I will also address. So going over proposals and comments, TB infection reporting. Estimates of latent TB infection in New York City range from 700,000 to 1.8 million, a very broad range because we really are basing this on modeling and don't have primary data to be able to actually estimate what the burden of LTBI, or latent tuberculosis infection, is in our city. Treating latent tuberculosis infection is the only way to reduce the risk of developing active disease and is a vital component of TB prevention efforts, including the strategy that's been put out by the CDC. So knowing more and treating LTBI becomes critical. Our proposal is to require laboratories to report all TB infection test results, including negative and indeterminate results. This would give the health department a better understanding of the prevalence of TB infection to help direct our public health resources so we can better direct toward LTBI to prevent active disease, and also provide information about testing practices to help inform provider outreach, laboratory diagnostic capacity, and strategy for TB elimination. We are very much focused on increasing use of immunological testing for tuberculosis infections such as the quantiferon, and this would give us the data to allow us to better identify targets for our work. We did receive 2 comments. 2 labs submitted comments requesting clarity regarding which types of TB tests need to be reported. 1 comment noted the high volume of negative test results per year. So we made some minor changes to the TB infection protocol to clarify that the new reporting requirement is limited to blood-based tests and any later developed tests for TB infection, and does not change reporting requirements for cultures and other tests used to detect active disease, addressing really what the concerns were by these 2 laboratories. Before I move to syphilis and pregnancy, I'll also state that in a personal communication with New York State, they are planning to pursue a very similar change in reporting to get the same data for both negative and positive blood screens for tuberculosis infection. So we are on target with that as well. Moving on to syphilis screening in pregnancy, I'll remind you that we are seeing a significant increase in congenital syphilis in New York City. We had 20 cases in 2018. Though numerically small, these are sentinel events, ones that we should never see. That represents a 186% increase from 2017, and it's the largest number in over 10 years. 11 individuals acquired their syphilis after their initial state-mandated prenatal screening. Symptoms of syphilis in pregnant persons may not be apparent, so routine, non-symptom or risk-based serologic screening during pregnancy, we believe, is critical. So the proposal is to mandate syphilis screening at 28 and no later than 32 weeks of pregnancy, and require that test results and treatment plans be documented in the medical record. A positive test triggers case management, enabling timely treatment to prevent adverse health outcomes to the pregnant person, fetus, and infant. Documenting test results and a treatment plan in the medical record, which is standard practice, will help ensure appropriate follow-up care. We did receive one comment, again, from the New York State Department of Health, submitting a letter in strong support of the proposal, and I'll just read an outtake of that. This proposed rule is in alignment with New York State Department of Health recommendations for syphilis screening in pregnancy and is expected to prevent a significant number of congenital syphilis cases. Modifying regulation to require screening at 28 weeks for all pregnant persons will permit detection and treatment of syphilis infection that occurs after the initial screening test but before delivery. This health code change will provide a best practice to ensure the health and well-being of pregnant people living or receiving prenatal care in New York City and will help to prevent congenital syphilis. The New York State Department of Health supports this change to the New York City Health Code. Moving on to our third proposal, exclusion of persons with enteric pathogens. People with enteric pathogens are required to be excluded from certain places of work or attendance until no longer infectious, for example, daycares or restaurants. The number of exclusions has increased in recent years due to improved surveillance and increased use of culture-independent diagnostic or CIDT testing. So just to compare, we had 187 exclusions in 2018 compared to 69 in 2015. So the proposal is to no longer routinely require consecutive negative test results to end exclusion. Health department experts will make an individual assessment in deciding whether additional tests are needed and when to end exclusion, including the type of infection and the test used to detect the pathogen. So I'll just briefly say CIDT is an example where molecular tests can identify the presence of genetic material of a pathogen, but culture may end up being negative, meaning there may not actually be pathogen that's viable anymore for transmission. Additionally, sometimes pathogen is detected for a significantly longer amount of time than the time that disease transmission is seen. So this is really right-sizing the rule to make sure that we're identifying a correct way to exclude folks based on the pathogen rather than just a standard strategy. Of course, other parts that are involved in deciding about exclusion are symptoms and treatment course, the individual's job responsibilities, likelihood of infectiousness based on length of time since symptom onset. So this will potentially reduce the time period of exclusion for some individuals while still maintaining our protection of the public health for these infections. And then finally, number 4, Campylobacter reporting. So Campylobacter is a bacteria that can be transmitted to people through contaminated food and liquid or animal feces. It's found frequently compared to other enteric pathogens. We actually had over 2,500 reported Campylobacter cases in New York City in 2018. Additionally, a lot of secular trends in testing are that people are using culture-independent diagnostic tests or PCRs that look for enteric pathogens. These tests are more sensitive for Campylobacter, and it results in some positive results that are later determined to be culture negative, meaning disease may not be present or transmissible disease may not be present. The proposal is to no longer require routine culture testing and isolate submission for specimens found positive for Campylobacter by culture-independent diagnostic testing. Given the high volume of Campylobacter reports, the health department generally investigates only clusters and does not use most of the isolates received from the laboratory. So in the scenario where we do have a cluster, the health department can request additional testing and still get these isolates from laboratories so we can pursue our outbreak investigation. This approach better balances laboratory burden as well as public health needs. Thank you.
Great, thank you. Any questions for Dr. Daskalakis? Yes.
Thank you for that.
Good morning.
Good morning. Is there any circumstance where this change in the rule might lead to a longer exclusion?
Most likely not. Theoretically, it could. I mean, I can imagine some scenarios where if a specific disease we knew had sort of more transmission risk with shedding, there may be a longer time that we would sort of pursue and maintain the exclusion. But I think for the most part, it would reduce the number of exclusions and also reduce the length of those exclusions.
Thank you very much.
Thank you.
A couple of very quick questions. One with TB, I know you're balancing the burden on labs, and I read the couple of comments with the benefit to epidemiologic investigation across the city. What is the burden for reporting? One of the comments seemed to imply, I think it was from one of the university labs, there's a lot of negative results, presumably the culture-independent tests make up the majority of them. Is this all electronically reported? Is it very easy, so the burden is minimal?
So very specifically in tuberculosis, we are looking for electronic laboratory reporting, so it's really making sure that we have a pathway to get those results, and it should, once automated, remain that way. So not lots of human labor, once programmed.
Thank you. Second quick one is around syphilis. Is there any plan to monitor compliance with the documentation requirement of a treatment plan?
So we already do, whenever we see someone who is a pregnant person with syphilis, we actually have a pretty significant response in the community to go out and see them and also pursue their medical record. This is in line with what we already do, but reminds the provider the importance of including that documentation. With that said, I think that an individual diagnosed with syphilis and an order for penicillin is probably enough to equal documentation of the plan. I'll also add one quick thing. Some of the cases of congenital syphilis that we've seen have been because of late treatment or inadequate treatment. So this is just another safeguard to make sure that we know exactly what's happening and can give advice to providers if necessary if they have to alter their course.
Great, thank you. And then the last question is about the enteric pathogens.
Mm-hmm.
And this is just probably a naive question, but is it possible that some of these positive PCR-based tests are, in the face of a negative culture, are really a reflection of a false negative culture, and a patient is still infectious, as opposed to documenting DNA material when there really is no infectious agents?
It could be, and that's sort of why there's a lot of different considerations that will be made in the plan for excluding. So the dynamics of the infection, sort of the science behind whether asymptomatic shedders are actually transmitters or not. So that will all play into the new strategy, if approved, that would allow there to be more sort of pathogen and individual-based planning for exclusion. So it's possible, I mean, in general, culture-based assays tend not to be as sensitive as PCR assays. In some scenarios, the PCR is so sensitive because you're picking up deceased organisms. But it's possible, and if someone is still symptomatic, our team would exclude them.
Thank you very much.
Thank you, Dr. Daskalakis. To follow up on Dr. Richardson's question, does the department or does the department plan to track the length of the exclusion period in schools and workplaces and other establishments?
We do now track it, and we will continue to track it.
Thank you.
Yes.
I want to understand, is this working?
Yes.
Oh, good. Thanks for this, it was really interesting. Just tell me a little bit more, because I obviously am ignorant about it. The purpose of collecting all these negative TB results, is it to give you an accurate denominator of how many tests you've done? What, do you do anything with it?
So we will be doing some work in the department very soon that focuses on provider outreach around latent tuberculosis infection. And one of our top line messages is it's important to use these interferon gamma release assays to assess individuals for latent tuberculosis infection, especially if they're from countries where they may have been vaccinated with BCG. So having an idea of both the positives and the negatives will give us a couple of important pieces of information. A, who and where is the testing being done. I predict, sort of looking at patterns of testing that we've seen in the past for other infections such as Zika, that some areas of the city where we would expect there to be a lot of uptake in this technology will have low uptake, and that will allow us to use our limited resources in reaching out to providers to really identify who we need to talk to make sure that they're doing the right testing. Then getting the positive test result does exactly what you said, which is we'll know what our numerator and denominator are, which will give us a better sense of what's going on with latent tuberculosis infection, a better estimate, which potentially will include some modeling, but better than what we have now.
Great. Ms. Redlener, and I want to remind members to keep holding their button so that the microphone stays live.
Thank you. Thank you for your update on the discussion that we had last meeting.
Thank you.
And as you may recall, we had a pretty robust discussion around the TB testing and some of the related messaging and targeting. So I'm just wondering, I know that this approval will allow laboratories, or will require laboratories to submit to the department both negative and positive tests, but so much of the impact of this change in the regulation will depend on the messaging, the outreach, and the targeting that you plan to implement later. So I'm just interested if you could update us. Will we hear about your ideas for targeting, messaging, use of resources before they get implemented, or what is the timeline for that aspect of it?
I would be happy to give follow-up as we're developing the plan. We're currently in the process of developing a provider detailing campaign with a provider action kit around latent tuberculosis infection that really focuses on correct management and testing for individuals who may be at risk for tuberculosis. So I would be very happy to present that once we have it sort of more mapped out. But we're planning in the next, I think, current year of development and then a launch the year after.
Yeah, I think as a board member, I would be very interested in hearing your thinking about the targeting, because I think this decision, this is just a reporting decision, but I think to look upstream a little bit, and if we're trying to identify, latent TB in, up to 1 million or more people, you're going to be recommending a new protocol or an updated protocol for screening. There are cost implications, there are, potential, negative treatment outcomes for latent TB in older people or other people at risk. I think it would just be an interesting and important conversation for us to know the thinking, as you develop it around the recommendations.
A couple quick footnotes. We're going to be using sort of what the national guidelines are for screening, so we're not going to invent new guidelines for who gets screened. But we're also going to recommend, a little bit of a switch in how people approach treating latent tuberculosis infection. So moving away from an extended course of INH to some of the more expedited and less toxic strategies that we've been using in our tuberculosis clinics. I can tell you that uptake of the non-INH strategies has been sluggish compared to what you'd expect, given that some of them really cut the time into half or less, with a lot fewer side effects and potential downstream complications even for folks who are older. So not changing the guidelines for what we're going to do for screening, but also really working aggressively in the messaging to say it's not just INH for 1 million years anymore. There's other options that you can use that are less toxic and potentially more acceptable to patients. And also making sure that people are aware of our clinics as a resource for sort of the technical assistance that providers need to implement these different strategies for treating LTBI. But I would love to come back and tell you as we sort of hatch more of the plans what they look like.
That's good to know. So this will make, the recommendations will be in alignment with the current national recommendations?
We won't be making any new recommendations at this moment regarding screening, just making sure that screening is happening per those guidelines, using the testing that we think is optimal.
Could we see I'd just be interested to know what the national guidelines are.
We'd be happy to send that link.
That
to
would
the
be great.
Great.
members.
Thank you so much.
Pam.
Thanks.
Just sort of in response in a way, having, and I guess Dr. Richardson knows what I'm saying, having been at Bellevue in am I supposed to press this down?
Yes.
Keep it down,
Having
please.
been at, There we go. Having been at Bellevue in 1992, when people with AIDS were afraid to come to the hospital because they were afraid they'd get TB, it needs, whatever, there's a balancing act here, and I think sometimes we don't really remember where we ended up previously, and we just, you know, however zealous this may seem, I always feel better actually knowing that it's going into effect, just for that reason, you know.
That's Carol.
What can be done from your side to educate us who are in the trenches with the patient to learn about the non-INH treatment for 3 or 4 months instead of 1 or 2 or 3 times a week?
Coming soon. So I think the main message is that we're going to be doing a lot of messaging around this that will include direct provider outreach. And so we have a lot of great strategies, and one that we have proven in infectious disease and other areas of health is our provider detailing work, which will be even better targeted if we're able to identify where under-testing is happening. So more to come and more education to come. Our tuberculosis team is here too, and I imagine they're nodding behind me and listening. So the answer is more education to come, specifically for providers, because they are our front line in the trenches for preventing active disease.
And I'll just emphasize, we have a number of different approaches that include both things such as the citywide health information, the CHI, which goes to all providers, tens of thousands of providers, and also includes in-person education. And so this will be one of those areas where we provide intensive support.
And as a footnote, there is latent tuberculosis infection CHI in preparation.
There you go.
Coming soon.
All right, so if there are no more questions, then we have before us consideration of adopting amendments to Article 11 and 13.
Second.
All in favor?
Aye.
Any opposed? Any abstentions? All right, fantastic.
Thank you.
Very much. We will now move to approval for publication, and we have Deputy Commissioner Schiff and Assistant Commissioner Hawkins that will do the presentations, and once the presentation happens and we ask questions, then we'll take each of these individually for a vote.
Good morning, I'm Corinne Schiff, Deputy Commissioner for Environmental Health, and I'm here with Simone Hawkins, who's our Assistant Commissioner for the Bureau of Child Care. We are here to present proposals to amend Article 43, which is child care serving children ages 3 to 5 in settings that are associated with a school. Article 47, which is child care serving children birth to age 5 in center-based care or shelter-based drop-off care. And Article 49, which addresses schools, public, private, and charter. So as an overview of what we're going to cover, we are proposing amendments to Articles 43, 47, and 49 in light of the new state immunization law, to Articles 43 and 47 in light of some new state and local laws. We want to clarify in Article 43 and 47 communicable disease exclusion requirements, expand Article 43 health and safety provisions and clarify enforcement protocols, revise Article 47 group size requirements, and set standards for Article 49 medical rooms. So I'm going to go through these topically, and then we'll summarize at the end for each article. So first, proposed updates on immunizations. As I'm sure the board knows, the public health law was amended to no longer provide for religious exemptions from mandated immunizations, and so accordingly we want to update the health code. We also propose to require that the department would review any requests for medical exemptions, and while those are pending with the department, the child would be able to attend the program. Proposed updates to 43 and 47 programs to require anchoring of furniture and to expand our current prohibition on crib bumpers. This is in light of new state laws, and also to prohibit the use of single-use polystyrene, also colloquially called styrofoam, in food service, and that's in accordance with a new local law. There's also new local laws on lead-based paint, and we would like to update 43 and 47 in light of those, As a reminder about our current requirements, 43 and 47 programs are already required to be free of peeling paint. Article 47 programs, in order to get a permit, have to be free of lead-based paint since May 1997. And in 43 and 47 programs that have lead-based paint, or if they don't know the lead content of the paint, they conduct an annual visual inspection. We call it a survey. They submit those survey results to the department, and they must remediate if there's any peeling paint. The new local laws require the child care programs to notify families of those annual survey results, and so we're proposing to require that notification within 30 days. And we're recognizing that child care programs communicate with their families in a variety of ways, and so we would allow for that flexibility. And we would require that they maintain documentation of that family notification so that we can check that. We will also be posting those results on our public-facing website, Child Care Connect. Another local law sets a timeline for remediation of any peeling lead-based paint done under a department order, and requires the department to set out some rules for circumstances that would allow an extension of time. And so we're proposing that a child care program that seeks more time would have to demonstrate a good faith effort to comply and show us that they have set interim controls to make sure that children are protected. Next, we are proposing some changes to the communicable disease exclusion requirements in 43 and 47. These are really clarifications to standardize the language and make sure that we're aligned with Article 11. Next, the board will recall we had a brief discussion at the last meeting about Article 43, which is, as a reminder, school-based, school-associated programs, and how some of the requirements were different from those in Article 47. We said at the time that we were looking at that, and we've now come back to the board with some recommendations about some additional requirements to align the two articles. That would include, would require a specific safety plan for the child care program, some additional requirements regarding fire safety, personal hygiene, and training. We also want to clarify in Article 43 the enforcement protocols. So we are defining what a public health hazard is. That's what would trigger an immediate closure, require notice to families when we order that closure, and then detailing the reopening process so that expectations are clear. For Article 47, which is our center-based programs, we're proposing to increase group size for 3-year-old classrooms from 15 to 17. These are classrooms with 2 teachers in the room, and we think based on the teaching and the square footage already required, these classrooms can support another 2 children. We are frequently asked for a modification to allow an additional 2 children because under Head Start said there are 17 children allowed, and so this would allow programs to maximize their funding, and we think that developmentally it's appropriate. And then finally, for Article 49, we are proposing to set the standards for the medical room for schools that have nurses. That was a lot, so to summarize, Article 43, we're proposing updates in light of new state and local laws regarding immunization, furniture, single-use polystyrene, and lead-based paint, to clarify communicable disease exclusion requirements, add health and safety provisions, and clarify enforcement protocols. In Article 47, the same updates in light of new state and local laws, the same exclusion requirement, clarification, and to adjust the program size. In Article 49, that same update in light of the new immunization laws, and to set standards for the medical room. And we can take questions.
I'll start on this side of the table, see if there are any questions from members. Dr. Klitzman?
Good morning, and thank you for your presentation and for all these important updates. My basic question is about what is the risk of lead-based paint hazards in these facilities? Or more specifically, do you have any data or estimates of the number of facilities that do or do not contain any lead-based paint, and the number and percent where there is documented lead-based paint or for which it's unknown?
So there's a couple of different questions there. So first, we don't have the numbers with us. I can note also that there is pending legislation at the City Council that would require all child care programs to be free of lead-based paint. I can say that in our, a couple of things. First is our experience is that the most meaningful risk for children in New York City is lead-based paint in their homes. As part of our protocol, as I'm sure the board knows, we receive all of the tests for blood lead levels in New York City. We review those daily, and we have a very active, as you know, investigation program, and we presented on that recently. When there is a child in child care whose case we are investigating, we do go to that program to investigate whether there is peeling lead-based paint there. Paint that is intact is not a risk. It's only when the paint is peeling. We also, as part of our routine child care inspections, are also looking for peeling paint of any kind. So there's multiple checks in the system to identify and address that risk.
Just a few follow-up questions. So the reason I'm asking the question is because if a facility has no lead-based paint and can document that, then there's no reason for them to do the annual survey, correct?
Correct, and it's not required. It's only
Right.
required if they have lead-based
Right,
paint.
so
Yeah.
I think it would be helpful for us, if it's possible, to understand the risk. How many facilities are there that either have paint of unknown lead content or previously documented lead-based paint? I think it would be helpful for us to know, what the magnitude is, and
Sure.
my guess is that it is declining over time. And then just one second question. Do you have any data on the number of instances in which you've documented a lead-based paint hazard in one of these facilities, in which a child with an elevated blood level attends?
I don't have that with me, but we can have that.
Yeah, I think that would be useful for us to know in terms of understanding the magnitude
Sure.
of the risk also. Thank you.
Yes.
Ms. Bradley?
Thank you. First of all, I think it's a really important effort to align the regulations in all facilities that provide, some sort of education on daycare, and so I commend that. My question is around communication to the families. I know that it was this year, there was communication to all the, about the public schools that were tested, and, to the point of specific rooms that were identified where, there was some hazard identified and some abatement was handled over the summer. What I found in that I work in some of those elementary schools is that there was a communication to the family from the Department of Education that I didn't see, and maybe I just missed it, I didn't see any particular communication from the Department of Health to families. And in the communication from the DOE, there was no particular guidance as to what parents should do if their 4-year-old was in a classroom last year where lead, a lead situation was identified over the summer. Should parents go back to their pediatricians? Should the child get a lead test? Should they not be concerned? Is there no follow-up? And I think, I don't know what the communication is that you're planning, but I think it would be very helpful to give some guidance from the Department of Health as to what parents should think about the fact that, oh, my child last year was in this classroom, or my child this year is in this classroom. Do I have to worry about anything? And I think that would be helpful.
So I think you're referring to the work that the Department of Education did over the summer to identify rooms where there was peeling paint and to remediate that. So the Department of Education did send a letter to families. That was something that we worked with them on, and this backpack letter, as they call it, did have some language. I don't have the letter with me, but it did have some language along the lines of what you're talking about for parents to understand the risks of lead exposure and some suggestions for talking with their healthcare providers if they are concerned. We will be providing guidance for childcare programs about what they can include in the letters home to families. We don't know who the children are enrolled in those programs, so unlike the DOE, we're not situated in a way that we can communicate directly with families. We will certainly will be posting this information on Child Care Connect, and we will certainly include information there. We have lots of information on our website for families, so we can make those links. I think it's a good suggestion. We can make links for families so that when they get this information from their child care programs and they're looking for more about what they might do as a parent, we can connect that information for them. You also noted that there was a lot of detailed information, for example, exactly which rooms were tested, and some, I did not include this in the presentation, but in the proposal, we are requiring that level of detail go home to parents.
Which I think is good. I'm wondering, when I read the letter, it was just from the Department of Education. And it's good to know that obviously, and I expected that would be true, that the Department of Health contributed to the information in the letter. Is there a way to just let parents know that? That this is a collaborative effort from the DOE and the DOH, this is a health impact, and the Department of Health is also concurring with these recommendations. I think it just would be, I read the letter, I had the letter, and I found it a little bit like, what should I, if I were a parent, what should I do? It wasn't clear what I should be concerned about. I know it's, check with your pediatrician, but I think that there could be a little bit more guidance around.
Thank you for that feedback, and I will certainly raise that with DOE colleagues for future communications.
Thank you.
Dr. Foreman.
This is no longer connected to it. Sorry about that. I got my foot got.
There we go. Good, thank you. All right, because my foot got caught on a wire. Thank you very much. I just want to follow up with a couple of clarifying questions. I'll start with lead. Just want to make sure I understand this correctly, if I was reading correctly. So there's a requirement that facilities under Article 47 that were, I guess, licensed after 1997 be lead-free, meaning no lead paint at all.
Correct.
Which means there exist some facilities licensed prior to that, which are not lead-free but have no lead hazards, such as peeling or tearing paint, and those are the facilities that need to have annual inspections. Is that correct?
Yes.
I just want to make sure I was
Annual self-inspections.
Got it.
Yes. And report those to us. Yes, exactly.
My second question about that is, you focused a lot about, you gave an example of a child where you receive an elevated blood lead level that attends one of these facilities, and as part of your investigation, you go and look for peeling and chipping paint. But I think we know that lead-based paint generated dust is an important source. So I wonder if your inspections include looking at friction surfaces, particularly windows and doors, and whether you do any lead dust sampling as part of your inspections.
It does include those friction surfaces.
But we do not personally conduct any. So yes, during our inspections, and just to clarify, all Article 47 programs are inspected at least once annually. So we do look at those surfaces, but we ourselves do not conduct dust swipe samples.
So how do you know if there's an issue with, really without doing dust wipe samples, how do you know if there's an issue with lead dust in the facility? If you've identified a child again, who has an elevated level and you're trying to identify the source.
And so the other thing that we are doing when we're doing these investigations is we're monitoring the child's blood lead level over time. and continuing to work with that family. So what we are looking for, all of the possible sources of exposure and watching that child's blood level, and if we're not seeing that decline, then we continue on this detective work, and so that might lead us back to that child care center, but as our first round of testing, we're not doing that dust wipe sample.
I think we know that the home is a more likely source, there's been more time in the home, they may have
That's right.
observation, et cetera. But
That's right. And there we are, when we do our home investigation, we're checking for lead-based paint, and if we don't find that the paint is lead-based, then we will immediately do that dust wipe sample.
Great, thank you. And then a quick question about medical exemptions from the immunization requirement. You had in your slide and in the regulation that students can continue to attend pending the department review of a request for a medical exemption. Is there a timeline for that review?
So I think we're going to be learning what will happen now that there's no longer a religious exemption, and so we put that provision in to be sure that we were not causing an undue hardship for families and programs. And we will have to see over time. Our expectation, our intention is to do that rapidly, but I think we need a little more time.
Great, thank you. And then the last question is about the medical room, the Article 49 facilities. You mentioned a requirement for a computer. I guess I'm curious about what the workstation with computer, what the intent of that is. I'm guessing it is to be able to access relevant medical information, so it probably should be with internet access. I know it's almost nobody has one without, but it is. I'm sitting here now without internet access, so it is possible not to have it.
Yes. I think, do we? And we have it. So yes. I think in the proposal itself, we do detail that, is my recollection. Yes.
Thank you.
Yes.
I have a question. Thinking about lead, other sources of lead, what's the department's policy on lead, water and lead in daycares?
So about 3 years ago, the board amended Articles 43 and 47 to require lead in water testing. That is a requirement. And those results, we do already post that on Child Care Connect, and so this edition will be like that. Like we have water results, we will be posting paint survey results.
Yes.
Just I wanted to second Dr. Klitzman's request. It would be very interesting to know how many facilities remain out there that were originally licensed before 1997 that still have lead-based paint and are undergoing self-inspections annually, and how many cases there are of children with elevated blood lead levels where a child care facility was found to have a lead-based paint hazard.
We will work on that.
I like that.
Yes, Karen.
Hi. I had a question about the immunization requirements for students, which I think is a very good idea. And I think I read in one of the documents that there was special consideration for children in transitional housing, students in transitional housing, to not let the lack of immunizations or documentation keep them from attending school. Could you just go over the requirements around, the timeline that students have to produce the documents and the exceptions for the students in transitional housing?
The change that we're actually making was due to a drafting error from two proposals ago, I think. So that's the reason for that change, and I think we'll have to get back to you on exactly. We'll have to write back to you about exactly what those requirements are.
Okay. But at this point, if a student doesn't have the documentation that's required for the immunizations, they're allowed to go to school. I think it was through December or something. And then there's no, there's no regulation where they're not allowed to attend school.
Hi everyone, Dr. Zucker, I'm the Assistant Commissioner for the Bureau of Immunization. So children had 14 days from when school started, the first day, to produce the documentation that they needed for immunizations to stay in school. They needed to start this vaccine series. and then there's a regular sort of schedule after that. There is a provision for people who are moving from out of state for up to 30 days to present their documentation.
And I want to just emphasize that the approach is to do anything and everything possible to make it easy for parents to get their children immunized. And the intent here is not to exclude children, but to help them comply with their requirements.
There are referrals in terms of where children can get vaccinated. We provide assistance with, for example, the citywide immunization registry. So on the public school side, as an example, the DOE actually brings in all the immunization data for all new registrants into their ATS database. So we're talking about really hundreds of thousands of shots for large number of kids. So actually it takes a burden off the school, and it also takes a burden off the parent in terms of bringing in those immunizations.
That's really great, and I know that it's there are many, there are more and more immunizations that are required, and I know that that's important to coordinate all of that. I'm just wanting to encourage the department to not keep children, keep children out of school for lack of adherence to some of those regulations, because absenteeism is such an important risk factor for kids, even at the young ages. So I'm not sure if it's spelled out here in terms of, any regulations. If they don't have all the information by the 30 days, what happens?
So I just want to clarify that it's actually the Department of Education who makes the final decision about excluding. It's not the Department of Health, and that's why I emphasize that our school nurses, our department staff that are working with schools, we do everything and anything possible to make it easy, because we are in complete agreement that we don't want immunizations to be a reason why children are excluded.
Great. So the regulation about students in transitional housing is the Department of Education. Yes. Thank you.
All right.
Just like, if I can just clarify, so there used to be a provision in the code that Corinne just referenced that had a provision regarding homeless children, and if children were homeless, there was an additional whatever time frame. That was inadvertently put into the code. There is no specific exemption under state law for homeless children. So the goal is to work with the families, but we needed to remove that because that was not recognized under state law, if that clarifies it. So I think that's what you saw, but that was bracketed because we took that out as a result of having been inadvertently added several years ago.
Okay, that does clarify that. So there's a recommendation for immunizations that the Department of Health puts forth, but the Department of Education.
It's more than a recommendation. There's a state law that requires every child who enters school to be immunized, right? That's a state law, and that's what we have put into our health code to reflect, right? That's been in the health code. The new piece that we've really done is remove the religious exemption, which now the state has done.
Right.
And our health code used to have references to religious exemption. And we've established a new process for medical exemptions. So whereas it used to be a provider would submit a medical exemption, we now have an additional step where those medical exemptions will be reviewed by the department, but the child can attend school until those exemptions are, finally reviewed and approved by the department.
Okay.
That makes sense.
I do understand it. I also know that, there are times when children may not be up to date on their immunizations, and I was just wondering what the regulation or the protocol is for that circumstance relative to their attendance.
If I may just clarify, when the schools do a fantastic job, just in terms of where we are, so we ended last school year for public school children, 98.9% of children were in compliance. Okay, so in terms of the number of children who aren't, there's a huge amount of effort that goes into making sure that children are properly immunized and they can attend school. We have survey data from the non-public schools, and compliance is not quite as high, but we're talking in the 97-98% range. So it really is, I mean, we're not particularly heavy-handed and out of school. We're required by actually the state through Article 6 to make sure these children have a place to get vaccinated and have referral sites. So we work closely with, again, schools, parents, the provider community to make sure that these vaccines are available. And because of the Vaccines for Children program, there are no barriers, there are no cost barriers. Children whose insurance don't cover vaccines, if they don't have insurance, they're all eligible for free vaccine. So I think that there's a lot of work that goes into getting these children immunized. If I may, on the medical exemptions, after California removed religious exemptions, they saw a fourfold rise in the request for medical exemptions, many of which were not valid, which is what our concern is, and we want to review them. But we should just keep that in mind, that there's experience, that we know that that's going to happen, and we've already seen it.
Thank you.
All right, any more questions? Terrific. So we will take each one of these individually. So we are proposing to amend Article 43 of the New York City Health Code and are seeking board approval for publication.
Second.
All in favor?
Aye.
Any opposed? Any abstentions? And then we will move on to proposed resolution to amend Article 47 of the New York City Health Code and are seeking board approval for publication.
So moved.
Second. All in favor?
Aye.
Any opposed? Any abstentions? Proposed resolution to amend Article 49 of the New York City Health Code, seeking board approval for publication.
Second.
All in favor?
Aye.
Any opposed? Any abstentions? Okay, all of these are approved for publication. We are now moving towards our next presentation on a proposed resolution to amend Article 48. And again, Deputy Commissioner Schiff and Assistant Commissioner Hawkins will be providing the presentation. Thank you. Sorry, number 5.
Good morning. So Article 48 governs day, traveling day, overnight camps, also camps serving children with developmental disabilities with 10 or more students, or children rather, under the age of 16, with 2 or more distinct activities, with one of those activities being considered high risk. Summer camps, specifically permitted under Article 48, only operate during the summer months, specifically June through September, and as previously said, must have these particular activities included. Our proposals to modify Article 48 is really intended to align with New York State requirements, specifically the New York State Sanitary Code 7-2 and New York State Public Health Law 2164. Also to detail the immunization requirements for children and to eliminate religious exemptions, prohibit pilling paint, and to require earlier submission of permit applications. Now to get into the meat of it. So the current version of Article 48 have very little definitions. So what we wanted to do was to expand that to really clarify our requirements and expectations of providers so they can properly comply with Article 48. We also wanted to enhance the requirements for specific required roles within camps, particularly the health director, the aquatics director, and the trip leader. We also wanted to codify staff clearances, the New York State staff exclusion list, and also the New York State sex offender registry. We currently enforce those requirements, but again, wanted to really get it into Article 47 so we can properly enforce it. We also changed some supervision requirements for children 6 years and older, allowing, really encouraging the buddy system, changing it from 1 to 5 to 1 to 6. The trainings for, again, these really required roles of the health director and aquatics director and the trip leader. Medical records for children and staff, and having those records on site at all times and available to the department upon request. And trips as well, particularly travel. We wanted to require and align with the New York State vehicle and traffic laws to require safety seats for children 6 years and younger. We also wanted to add details on immunization requirements, and similar to Article 43 and 47, eliminate the religious exemption. To assist programs, especially those starting in early or mid-June, we wanted to extend from 60 days to 90 days the required time for them to submit their application to us. As previously mentioned, record keeping, allowing records to be kept electronically or in paper form. And again, as we learned from previous situations, having that specific language in the code saying that they must provide it to us immediately upon request for review. It's similar to Article 43 and 47, as Corinne previously presented. We also wanted to include and align language for communicable disease under Article 11.
All right, thank you.
Any questions? Thank you.
Any questions? Dr. Plum?
Hi, thank you very much. I have 2 very quick questions. You mentioned the requirement for safety seats for children under 6. This may not apply to you. Is this a requirement that applies to all vehicles transporting kids, like to daycare and schools? Because I believe we use school buses that don't have that.
So for Article 47 childcare centers, that is also a requirement.
Okay. And then the second very small thing is the last requirement for keeping health records either on paper or electronically. If it's not in there, and I didn't read it, I would include a requirement for backup of that data if it's electronic. Still happens frequently that important data is not backed up. It's not expensive, but if it's not written, some people might neglect it.
So we didn't specifically include language on requiring them to back up the data, but we can absolutely encourage that through technical assistance.
Any other questions? Yes.
Thank you. There's a lot of information in this document, so thank you for the complete work. I just noticed on page 11, when we're talking about the checking the Criminal Justice Services Sex Offender Registry, it says the camp director must verify, it's number 3 under records on page 11. The camp director must verify whether any staff or volunteer is listed on the sex offender registry prior to the day. But it doesn't really say here, maybe it says someplace else, what they do if they are listed. So, I know it, I'm assuming there's, they're excluded, but it doesn't really say that. It just says they need to check the registry.
Yes, so they are required to not hire, extend and hire to that person, and that person's obviously not required. In some circumstances, and this gets very complicated with Article 48 programs, required to comply with the Child Care Development Block Grant requirements, so those legally exempt subsidized programs. Normally those would be automatically excluded, but there are some provisions allowed for these programs to not have individuals directly in contact with children if not supervised by someone who is cleared and do not have any findings or hits as a result of any of the clearance requirements.
So it doesn't, if a person is listed on the sex offender registry, it's not an automatic exclusion from working with children?
I'm sorry?
Is that what you're saying, that if they're listed on the sex offender registry, it's not an automatic exclusion from working with children?
So, no. They can enter into a corrective action plan with the department stating how this person, and for example, let's say it's the custodian working, we would say that they cannot be left unsupervised with children without someone being properly cleared, always in constant supervision of that individual and the students.
So does it make sense to maybe add another point that says something, a little bit of, as opposed to just checking, if they are listed, then, there are certain circumstances where they're excluded or other circumstances where there's extra protections, required.
Absolutely, we can clarify in the next round.
Any other questions? All right, so we have before us proposed resolution to amend Article 48 of the New York City Health Code, seeking approval for publication.
So moved.
Second.
All in favor?
Aye.
Any opposed? Any abstentions? All right, thank you very much. And so that brings us to the end of our agenda. Again, another packed agenda helping us protect the city, and I want to thank you all for your service. We are adjourned.
Thank you.